Whoever the host is. Okay.
There we go. That answers our question.
All right.
All right, we're going to go ahead and get started. So welcome to the Morris and Carolyn Barkon Lectureship in Gynecological Oncology Survivorship. I'm Colleen Straub. I'm Director of Development at Magee-Womens Foundation, and I happen to be stepping in today for Janice Devine, our Executive Director, who was not able to join us today, and she sends her apologies and asked me to host the meeting instead. I'd like to really take a moment now to extend our special thanks to Doctors Beverly Barkon and Frank Lieberman for their continued and long-standing support. It is their dedication that allows us to continue keeping both our healthcare professionals and our survivors informed about the latest developments that impact care. The road to surviving cancer from diagnosis to recovery is a long one. The hurdles you face in guiding patients through this journey can be challenging, which is why we are so honored to share the expertise of Dr. Stanley Roxon with you today. Dr. Roxon is internationally recognized for his pioneering work in lymphatic disease, a complication that can affect cancer patients, people who experience head and neck traumas, or other physical traumas. As you know, it can profoundly impact a patient's quality of life. Dr. Roxon will be sharing with you his insights as well as emerging issues and strategies in navigating this complex task. Our second hour will be for cancer survivors. And as you know, they are the reason we all do what we do, and they are very much top of mind. If you want to join in that session, which begins at 6:00 p.m. Eastern Standard Time, or Daylight Savings Time, I guess we're in now, you can use the same code to attend and listen in. And with that, I would like to turn the discussion over to Dr. Beverly Barkon, whose courage, vision, and generosity has been the driving factors in gathering us all together today. Dr. Barkon.
So I want to welcome everyone to the 2021 Survivorship Workshop with the wonderful Dr. Stanley Roxon. My husband, Frank Lieberman, and I are happy to sponsor this event. Dr. Roxon was the presenter in our inaugural lecture several years ago, and we're honored to have him once again, though under quite different circumstances because of the pandemic. We've dedicated this lectureship in memory of my parents, Morris and Carolyn Barkon. Neither of them faced cancer in their lifetimes, but they instilled in me the courage to face it in mine. I am a 17-year survivor and counting of gynecologic cancer. Each survivor takes this journey alone, although we are accompanied by our friends, our families, our communities, and our medical teams. We are all survivors of one of the most significant challenges that confront human beings. We lived through the diagnosis and treatment of cancer. We have come to the other side and we are here. It's not easy. Survivorship is another part of the journey, and it doesn't come without cost. Though there is a common theme, each of our cancer journeys has been different because each of us is different. When it came time to think about how to give back and pay forward, my husband and I wanted to create opportunities for both physicians and survivors to learn about the myriad issues that face survivors and their families, and to make connections between the medical teams and the support resources so that positive action can be taken to ensure that this part of each woman's cancer journey results in the highest quality of life possible. I want to take a few minutes to thank the people who made all of this happen, including Denise Wickline and Laura Jacko. Please forgive me if I didn't mention you. Be assured that your efforts were most appreciated. Thank you. And I'm going to switch now to an introduction to Dr. Roxon. Dr. Roxon is the Alan and Tina Neal Professor of Lymphatic Research and Medicine at Stanford University School of Medicine. After earning his medical degree from Duke University School of Medicine, Dr. Roxon completed his internship, residency training in internal medicine at Brigham and Women's Hospital of Harvard Medical School in Boston, Massachusetts, and a fellowship training in the cardiac unit of Massachusetts General Hospital. Harvard Medical School. He is a fellow of the American College of Cardiology, Society of Vascular Medicine, American College of Angiology, and American College of Physicians, as well as a member of the International Society of Lymphology, American Society of Internal Medicine, and the Paul Dudley White Society, among others. As a principal investigator or co-investigator, he has been involved in numerous clinical trials researching various aspects of lymphatic disease, vascular biology, and cardiovascular medicine. His basic research involves the investigation of disease pathogenesis and identification of biomarkers of lymphatic diseases, as well as research into molecular and pharmacological therapeutics. As a professor of medicine, Dr. Roxon serves concurrently as the Stanford's Chief of Consultative Cardiology and the Director of the Stanford Center for Lymphatic and Venous Disorders. He is the Editor-in-Chief of Lymphatic Research and Biology and sits on the editorial board of Angiology. Dr. Roxon works closely with the National Institutes of Health in an advisory capacity to advance the agenda for lymphatic research. He has been a frequent invited lecturer at national and international meetings, congresses, and societies. He is the co-founder of the Lymphatic Education and Research Network, or LEARN, and has served as chair of the inaugural Gordon Research Conference entitled Molecular Mechanisms in Lymphatic Function and Disease. He is the co-author of Lymphedema, a concise compendium of theory and practice, now in its second edition. Dr. Roxon has authored more than 200 scientific papers, reviews, book chapters, and books devoted to various aspects of lymphatic biology and disease, vascular biology, and cardiovascular medicine. We are in for a treat. Thanks. Dr. Roxon, it's yours.
Thank you. Thank you so much, Beverly. I am deeply honored to be invited not once, but twice for your very, very important conference. I'm afraid we may have exhausted the patience of the audience in just listening to that introduction.
I'm sorry.
I apologize. No, I feel very, a little bit embarrassed to listen to all of that, but I'm going to quickly put on my slide, share my slides so that everybody can see what we are talking about. And then we'll go ahead and get started. So I've taken the liberty of changing the topic title a little bit with a hat off to John Steinbeck. I'm calling this Of Mice and Men, and I hope it becomes clear why I've chosen that title in a moment. But I'd like to talk about some of the more modern research surrounding lymphatic disease and lymphedema in particular. And again, I think it'll be clear why we're talking about mice and men. I do want to say that this is heavily populated by my own work because I'm most familiar with it. I don't want to pretend that I'm the only person doing work in this realm, and I will touch on a little bit of the other areas, but this gives me an opportunity to share the things that I know best. Before I begin, I'd like to just publicly state my disclosures. I have received grant support from Eiger Pharmaceuticals and Fiberline Incorporated, and I will touch on data that emanated from both of those sources of grant support. I think this cartoon really embodies the most important message that I've encountered in my 30 years in dealing with lymphedema and lymphedema patients, which is that it is of extraordinary importance to those patients, and unfortunately, historically, has not been as important to their healthcare providers. And I think the purpose of today's talk and this program is to serve in some ways as a source of enlightenment to try to tip the balance more favorably for patients. I will say that in a practice that is predominated by cancer survivors, what I typically encounter is that the patients who have lymphedema from cancer therapeutics almost routinely say that the impact of the lymphedema dwarfs the impact of their cancer experience. It is really important to these patients and therefore should be important to all of us. So in order to move forward, the first thing we need to do is dispel a very common notion, which is that the lymphatics are somehow a sewer system within the body. That's a gross oversimplification, and in many cases, it's simply not correct. So let's start by talking about the system that becomes broken in lymphedema and other lymphatic diseases. I prefer to think of the lymphatic system as an immunovascular network. What that means is not only is the lymphatic conduit essential to the integrity of the cardiovascular system and the preservation of the circulation, but it also is centrally part of the immune system because all of the lymphatics, of course, pass through these vital immune organs that we call lymph nodes and other lymphatic tissue. And it is the ability of the lymphatics to bring the lymph nodes and the immune system up to date with what is happening in the periphery of the body that allows the immune system to function. So when the lymphatic system collapses regionally or more profoundly, we lose not only circulatory integrity, but immune integrity. And I think that should help us understand why this is such an important set of disorders. So as I said, we're going to be talking about mice and men. And the reason is that much of what we have learned about the lymphatic system in the last 20 years emanates from mouse model experimentation. Now, mouse models are not always uniformly predictive of what we will encounter in the human situation, but I'm happy to say that in my own work and in my knowledge of work in lymphatic development and lymphatic signaling and lymphatic circulation, there is tremendous parallel between mice and humans. And because we can harvest information rapidly through this system of gathering biological information, I will be talking a fair amount about what we learned from mice during this hour. So just a quick summary of what our topics will be as I go through this. I want to say something briefly about lymphatic development because it does invest so much about what we know about the molecular underpinnings of the lymphatics. I do want to talk about biomarkers. I will be saying a little bit about the surgical approaches to lymphedema, which are experiencing a true blossoming within the last decade. I will talk about my work in pharmacologic therapeutics of lymphedema, and then just a glimpse to the future. So this is a mouse embryo, and what we know about the development of lymphatics in the human body, we've learned from the mouse. And this is a very oversimplified schematic, but I just want to bring home the point that the lymphatics actually bud off of the embryonic venous system and share many of the attributes of the venous system, but it is a series of very important molecular signaling mechanisms that allow this transformation to occur and eventually allow this part of the circulatory network to separate itself completely from the blood circulation. Now, what we have learned, and we really don't have time to go into great detail on this, are the various molecular steps involved in each of these sub-processes that give us a mature lymphatic circulation. But one of the things that it has helped us to understand, and what we in turn have learned in the human setting, is where the mutations occur that relate to the inherited forms of lymphedema. Now, that's not specifically a part of today's talk, although interestingly enough, the inherited lymphedemas that have nothing to do with lymphatic trauma or cancer behave virtually identically to those that emanate, for example, from GYN malignancies. So much of this information is unitary, but we have learned a lot about the molecular fabric of this system because of the individuals who have individual defects that allow them to develop lymphedema or other lymphatic malfunction. I also want to highlight the fact that lymphedema, and specifically hereditary lymphedema, sits within a network of diseases that include a variety of malignancies, a variety of vascular malformations and other syndromic presentations. So to understand lymphedema means that we understand actually a broad array of diseases and vice versa. And basically, it is my philosophy that these hereditary and inborn conditions really provide us a keyhole through which we can glimpse the contents of the room on the other side. By learning about individual mutations that might affect a really rare, small subset of patients, we might learn something very valuable that will affect literally millions of survivors of gynecologic or breast cancer who develop lymphedema as a consequence of it. One example of the advances that have been made in the last several years in this particular realm is the recognition that many of the lymphatic vascular malformations are actually somatic, or the result of somatic mutations in a specific gene called PIK3CA that sits upstream of various molecular regulators of vascular growth. So when you have the mutated form of the gene, your body no longer, at least in the region of the body that harbors the somatic mutation, your body is no longer able to control the rate of vascular growth. And this leads to lymphatic and other forms of vascular malformations. The take home from this is that we have a group of drugs that is readily available. In fact, they emanate originally from the realm of cancer therapeutics that inhibit the pathway that is responsible for lymphatic vascular overgrowth. These are clinically available and FDA approved drugs. The prototype of this would be a drug called sirolimus. And what we have learned in the last 10 years is that we can apply this form of pharmacologic inhibition to actively retard the growth of these lymphatic and other vascular malformations. Here you see a mouse model of a mouse that has had one of these vascular tumors implanted under the skin without receiving the therapeutic, and then in the presence of sirolimus or rapamycin therapy, you see the shrinkage of the vascular growths. And we have now been using this form of therapeutic for at least the last 10 years in patients with often life-threatening or life-compromising vascular malformations, including those that are specifically lymphatic. Moving on to biomarkers, I've long been interested in identifying biomarkers because of the importance that this step will have in developing therapeutics, as well as to a degree in diagnostics. And most of my work, again, resorting back to the mouse, has been in a murine model in which we create lymphedema that would simulate or replicate what would be observed, for example, in a cancer survivor with lymphatic trauma from radiation or surgery. So we ablate the lymphatic trunks at the base of the mouse tail. The mouse develops lymphedema beyond the site of surgical disruption. And in this model, we can readily, through photographic means, very accurately calculate volumes of the mouse tail, which would be the equivalent of the leg or the arm of the affected human individual. And we can also use the tissues that we derive from the tail to study the disease process. So here you see the skin of a mouse with lymphedema that has been acquired in this model, and compare it to the normal, where you see the tremendous thickening of the dermis, the inflammatory cell infiltrate, the dilation of the lymphatic microvessels, and the overall increase in dimensions of the skin. We've used this model to actually do transcriptional profiling to determine which genes are up and down regulated in the setting of lymphedema when compared to a surgical sham control. And what we found in this model is that remarkably, most of the signaling, and not terribly expected before we did this research, most of the signaling is in the realm of the inflammatory response and the immune response. So we quickly got the notion that lymphedema, no matter what it looks like, no matter how much it looks like a clogged sewer system, is in fact an inflammatory condition that may be amenable to treatment by dealing with the inflammatory effects. We subsequently looked at a similar manifestation in human lymphedema, and here we harvested skin from a lymphedema affected limb and also from skin of the contralateral unaffected side to be able to look at differences in signaling in the skin itself. And once again, our findings were heavily predominated by inflammation and immune responses, as well as other changes that we recognize as being very central to lymphedema, including adipose overgrowth, overgrowth of the skin itself, vascular changes, and as we talked about a moment ago, mTOR signaling having to do with vascular growth. So I want to share with you the results of some work that is now almost 10 years old, in which we used this approach to identify biomarkers that circulate in blood that correlate strongly with the presence of lymphedema. And without the ability to go into a great deal of detail, what we ended up doing with data like the data that I've just shared with you in the mouse is that we did logistical regression analysis to look for the minimum number of molecular mediators that would identify lymphedema and separate it from non-lymphedema controls. And basically, we found that with as few as 6 of these protein markers, we could identify lymphedema with about 90% confidence. Now, these were not selected to fall within these categories. In other words, this was a prospective identification of biomarkers and then identification of their signaling effect. And as it turned out, we have covered most of the protein manifestations of lymphedema, which would be abnormal lymphangiogenesis, inflammation, fibrosis, and signaling in adipocytes, which are all the hallmarks of well-established lymphedema. Now, moving this work forward, I'd like to share with you some work that we have just published within the last year, in which we feel that we've identified the first universal biomarker for lymphatic disease that is not specific to lymphedema alone, but to a lymphatic disorder in general. And we were driven for this because within the field of lymphedema, there is a very important differential diagnosis which frequently presents itself. Does the patient have lymphedema? Does the patient have lipedema, which is what I will call a cousin disorder that creates a simulacrum of many of the attributes of lymphedema, but with distinct differences? Or is this obesity, what we might call lifestyle obesity, changing the appearance and behavior of the limbs? And it's not always feasible to accurately differentiate these 3 entities, and in some cases they certainly coexist within the same individual. For this particular work, in the group of 50 or so patients that we ultimately studied, we harvested blood and purified from their blood these circulating particles called exosomes, which are particles that are created within cells and tissues and are extruded into the interstitium and ultimately the circulation. And these packets contain a variety of important molecules, including proteins and RNA and DNA. In this case, we were interested in the protein content of the exosomes. We initially performed some work again in our friends, the mice, and we chose to look at wild-type mice and compare them to this heterozygote condition in which the mouse eventually develops both a lymphatic defect and obesity, and compare that with another model in which there is obesity that develops as a result of a disorder of the leptin pathway. And by comparing and contrasting the exosome profiles in these 3 sets of presentations, we were able to determine that there was a single protein within the exosomes that seemed to segregate with the lymphatic disease, but not with the other conditions, and that is called platelet factor 4. Now, despite the fact that platelet factor 4 carries the name platelets, in fact, this has nothing to do with platelet function in this particular circumstance. Platelet factor 4 is actually also an inflammatory mediator that is elaborated by macrophages. We next tested the utility of platelet factor 4 by looking at a group of 50 human subjects who had some variety of lymphatic disease, either lymphedema, lymphovascular disease, or lipedema. And what we found, sorry, I'm just going buzz ahead so we don't run out of time. What we found is that when we did an area under the curve analysis, we attained virtually diagnostic level accuracy in terms of sensitivity and specificity for all three of the lymphatic subsets that did not cross over into the non-lymphatically affected individuals. So this is a very interesting finding in that it ties together some of the unitary attributes of lymphatic disease across phenotypic presentations, and also once again underscores the very important inflammatory nature of lymphatic disease in general. I'd like to turn next to surgical approaches for lymphedema. There has been an increasing practice to intervene in these patients surgically over the last decade, and the surgeries fall into a few different categories. Most importantly, and this one is available, I believe, across the spectrum of lymphatic presentations, is so-called debulking surgery, in which we don't attempt to do anything to improve the underlying lymphatic function, but recognize that there is tremendous cellular and tissue overgrowth, predominantly of adipose tissue in longstanding lymphedema, and that this eventually poses problems for mobility, for comfort, for fitting of garments, and for appearance. And it is now readily feasible to operate on these patients with using a very highly stylized approach of liposuction performed under general anesthesia in a bloodless field, in which we can effectively remove all of the tissue overgrowth, and with assiduous use of compression, we can actually restore the limb volume to pretty close to normal, in most cases identically to the normal unaffected side. Beyond that, there has been a proliferation of approaches to try to improve the intrinsic function of the lymphatics, and this either takes the form of lymphaticovenous anastomosis, where we divert lymphatic flow into nearby veins, or in some cases, what is called vascularized lymph node transfer, which is a graft procedure in which lymphoid tissue is placed into the lymphodematous zone with the intention of the lymphoid tissue stimulating more adequate lymphatic repair and thereby improving function. Now, one of the problems with that latter approach is that it is not universally successful, and it's not always clear why that occurs clinically, but from preclinical studies, we understand that the success of vascularized lymph node transfer has very much to do with the success in which the engrafted lymphoid tissue incorporates itself into the surrounding lymphatic network. And that is very much a growth factor mediated process. For that reason, I've been involved in work over the last several years in developing materials that will help to improve the engraftment with vascularized lymph node transfer. And basically, we have developed this biological scaffold, which is called the BioBridge. It is made of normal mammalian collagen that is purified and rendered non-antigenic. And in a subsequent nano process, we highly align all of the collagen fibrils in a unique longitudinal array, which when you look in cross-section, looks a little bit like a bunch of spaghetti that you've just taken out of the box before you cook it. But these crevices that you see in between these collagen fibrils are very conducive to the growth and propagation of lymphatic endothelial cells. And we find that, in fact, this does help to accelerate and propagate the lymphatic repair process. Here's a little higher magnification of the cross-section of that same fiber that you saw being held up by the surgeon hand in the prior illustration. So this is a thread-like multiluminal collagen scaffold with highly aligned fibrils, and this large surface area is very conducive for cell attachment, alignment, migration, and it enhances the natural maintenance process of the lymphatic vasculature. So when we place this material in tissue culture that contain human lymphatic endothelial cells, we see that they are very inclined to grow over this material and to align themselves in the same longitudinal overlapping fashion that they would have if they were within the surface of the vessel itself. So we decided to test the efficacy of this scaffold in a large animal model. We're going away from the mice for just a minute. This is a large animal model of the type of lymphedema that would occur in gynecologic cancer survivors. So we remove, in this case, in the swine, there is a single lymph node in the inguinal region which can be surgically removed. You can see the radiation port that was applied thereafter, and over the next 9 to 12 weeks, the animal develops well-developed lymphedema. When we go in and a subsequent surgery, place these scaffolds across the zone of surgery, what we see is resolution of the lymphedema and growth of new lymphatic collectors that are clearly evident in apposition to the remaining collagen fibers. Now, these fibers are completely resorbed over 9 to 12 months, and they are otherwise entirely inert, but they serve as a beautiful bridge for lymphatic vascular growth. The hope, of course, is that this could be used adjunctively in human surgical interventions. Just to show you that these are, in fact, lymphatic collectors, this is immunohistochemical staining that shows that we have attributes both of lymphatic endothelial cells stained in red and the smooth muscle coat of collecting vessels that is stained in green. Now, I want to talk about maybe the most exciting aspect of this work, and here we're going to go back to the mouse model, and that is that we feel we may have an intervention that in fact has the power to prevent lymphedema in these settings where lymphedema is so highly prone to occur. In this particular set of experiments, we placed the scaffolds across the zone of lymphatic damage at the time of surgical lymph node removal and prior to radiation therapy. And the good news is these fibers are radio resistant, so they are not really destroyed if the patient has subsequent radiotherapy. But what we found is that when we use these preventively, we actually encourage the growth of accessory pathways for lymphatic drainage to the contralateral side of the animal's body, and these animals did not develop lymphedema, whereas the control subjects without the scaffold in fact developed lymphedema and did not develop collaterals. So the thought is that one day we might actually be able, with a very simple adjunctive step at the end of, for example, in breast cancer, at the end of axillary lymph node dissection, to simply place these scaffolds in the surgical field to encourage lymphatic healing in the post-surgical state and to minimize the likelihood of radiotherapeutic damage during the radiation phase. And the same would apply presumptively in the setting of gynecologic malignancy. So here's a close-up view of those collateral bridging lymphatic vessels that have developed because of the presence of the scaffold in place. I'd like to move on now quickly to drug therapy, again, resorting to the same animal model that I mentioned to you earlier, because we can use this model to then have a therapeutic intervention and measure the impact of the improvement. And basically, to make a very long story very short, we have been able to demonstrate that by a very targeted anti-inflammatory approach, we can actually reverse the histological changes of developed lymphedema in a very short period of time. And at least in the mouse, this correlates to a dramatic reduction in edema volume as well. We subsequently took this work into the human setting, and this is now published as of a couple of years ago. This was a pilot study, but it was placebo-controlled, and we were able to demonstrate that the use of this very targeted anti-inflammatory therapeutic was able to reverse the changes that we typically characterize as those of advancing lymphedema. As lymphedema worsens and increases in stage, we see increasing thickening of the tissues and the structures and decreasing impact of the pitting edema that typifies the early disease. So this would be an example of untreated lymphedema, a well-developed stage 2 lymphedema with a skin thickness of about 35 millimeters. Normal would be perhaps 0 to 2. This is the same patient after 16 weeks of therapy. with the drug on a daily basis, no other intervention added, and you can see the skin has reduced in thickness to about 3 to 4 millimeters of mercury, so nearly normal. And basically that is what we observed throughout the study population, but not in the placebo-treated group. And it was accompanied by, again, by using skin biopsies, we could see this dramatic improvement in all of the histological attributes of the untreated lymphedema. Well, we were using a drug for that particular work, which is a non-steroidal anti-inflammatory, but it is a very unique non-steroidal anti-inflammatory. So all of the drugs that we're all familiar with as being on the drugstore shelf in Walgreens or CVS or what have you are cyclooxygenase inhibitors, and they inhibit the formation of thromboxane and other prostaglandins that have inflammatory attributes. The drug that we were using, while it also inhibits cyclooxygenase, in parallel inhibits a second pathway called lipoxygenase, which is a pathway that is particularly active, for example, in airway disease, where the production of leukotriene C metabolites will cause bronchospasm and so forth. But in this case, we had a drug that inhibits both cyclooxygenase and lipoxygenase, and we became curious about whether the effect in lymphedema, either in the mouse or in the humans, was based upon this pathway or both. And what we learned in principle is that, in fact, it isn't attributable to the lipoxygenase pathway and has nothing apparent to do with cyclooxygenase inhibition. And the specific metabolite that seems to drive lymphedema is called leukotriene B4, which is a specific downstream product of lipoxygenase activation. And what we found, and again, I'm sorry I don't have time to go into great detail, is that when we give a specific leukotriene antagonist in the mouse model, we can take what amounts to a lymphoscintigram in the mouse tail, which completely disrupts in the presence of lymphedema, to a nearly normal pattern within 1 week after treatment. And this correlates with imaging that we can perform with fluorescein labeled materials, near infrared compounds that actually allow us to see lymphatic flow. We see restoration of lymphatic flow from the mouse tail to the body of the mouse just by administering this LTB4 antagonist. Now, we have completed a small clinical trial. It was placebo-controlled. It involved 55 patients. And I'm sorry to say, having nothing to do with my design, but having to do with the budget of the study, it was indeed underpowered to assess the primary endpoint. So we're not going to be able to say anything about whether this treatment approach actually is effective in the way we did in the ketoprofen study, but we are actively underway studying the body fluids that we were able to harvest during the study, and we think that there are going to be molecular markers that will emerge from that study that will teach us a lot about what we actually accomplished and that will invest our future investigations. But just to tantalize you a little bit, we know that in my experience type statements don't really bear much weight in rigorous science. I do want to show you the last patient that we enrolled as an active drug recipient in the trial. This, in fact, was a GYN malignancy survivor, and you can see the severity of her left leg lymphedema. She successfully took the drug for 6 months and experienced a tremendous clinical improvement. And she recently sent me a follow-up picture. This is 18 months after she stopped taking the drug. And basically, what you can see is that her leg became nearly normal and has remained so, and requires only the use of a very light compression garment. So that's not proof of anything, but it certainly intrigues me, and it spurs me onward to want to continue to investigate this approach as something that may really be a game changer in the future treatment of lymphedema. We continue to explore other pathways as well. For example, we just published this study in JCI looking at the role of lymphatic HIF2 alpha in lymphatic remodeling. So there are other targets that I believe we'll be able to address in future. I think it's very much of an evolving field. So what about the future before I conclude? I think we need to get much smarter about the molecular underpinnings of lymphedema and other lymphatic diseases. We need to make progress in therapeutics and surgery and all the things that I've touched on. But I think we also need to begin to touch on our knowledge or ignorance about the degree to which lymphatic disease is a cause and the degree to which it is an effect. We know that this system plays a tremendous role in cancer biology. It plays a tremendous role in immunity and inflammation. And increasingly, we are recognizing that lymphatics in various parts of the body play very specific roles in pathogenesis and natural history of disease, like inflammatory bowel disease, obesity, and other metabolic disorders, including dyslipidemia, atherosclerosis, congestive heart failure, myocardial infarction, narrow angle glaucoma. There is a very specific lymphatic system within the eye that is affected in narrow angle glaucoma. Increasingly, there's evidence that central nervous system lymphatics may play a role in the pathogenesis of Alzheimer's and other neurodegenerative diseases. So we have a huge field to exploit and many, many disease states to favorably influence by getting smarter as lymphatic biologists and clinicians. So years ago, I coined a term, if you will, the lymphatic continuum, to recognize the fact that the lymphatics are important well beyond lymphedema. And I think we need to recognize that this list is going to continue to grow in the years and decades to come. And hopefully we can reap the power of the lymphatics to help to restore health in those individuals who are so affected. So in summary, I would like to believe that in the long run, anything will be possible. We just have to be smart enough to do it. So with that, I will unshare my screen and hopefully we have some time for some Q&A.
Does anybody have any questions that they want to put into the chat or ask Dr. Roxon? Can you see the chat, Dr. Roxon?
Yes, so the question I'm reading right now, when you speak of surgical approaches to remove lymphedema masses, does this mean removing large masses that develop along the limb? No, I'm sorry, I wasn't quite clear and perhaps I should have shown an illustration, but let me explain it this way. Let's assume for the sake of argument that you have a patient who has a single leg lymphedema and it's pitting. And if you do volume measurements, you determine that there's 2 liters of extra fluid within that limb. And then you treat the patient and you get the extra limb volume down to about 1400 cc's. What will happen, unfortunately, somewhat inevitably to most of those patients is that over time, that 1400 cc edema will transform from a pitting, responsive edema that represents free fluid within the interstitium to a 1400 cc volume difference that is non-pitting. And typically that means that over time, there has been overgrowth of the subcutaneous adipose layer along with overgrowth of the cellular contents of the skin as well. And you basically get a milliliter for milliliter transformation of free fluid into tissue mass, and it's largely fat. Now, my teleological explanation for that is that the body is actually elaborating an internal sponge to serve as a conduit to bring that fluid out of the interstitial space and into the cellular space, and thereby to be in some equilibrium with the circulation. But long story short, if you take that individual who's now walking around with 1400 cc's of extra volume in that limb and perform suction-assisted lipectomy under general anesthesia, and then apply compression appropriately, you can bring that leg back down to a normal size and use continued compression to maintain that benefit. That's really what I was talking about. I hope that is clear now. Now, the next question is, what are some examples of NSAIDs similar to the one that seems to have been effective in the study? Well, unfortunately, fortunately or unfortunately, that drug is the only one in the NSAID class that has this lipoxygenase inhibiting capacity. And it is clinically available. The drug is called ketoprofen, and it's a prescription NSAID. The issue that I want to underscore is that I don't think that anybody should consider this work to be the definitive phase 3 clinical trial. And certainly there is no FDA indication for ketoprofen, but it is available for clinical use. My one caution for clinicians is that it is very important to highlight to yourself and to the patients the downstream consequences of chronic NSAID use. The FDA, once we completed our study, fortunately or unfortunately, the FDA released an advisory indicating that NSAIDs, all NSAIDs, are considered to carry a small but defined cardiovascular risk and are therefore relatively contraindicated in individuals with hypertension, with history of atherosclerosis, with prominent cardiovascular risk factors, history of stroke, and so on. So all of those things need to be borne in mind, as well as being aware of the NSAID use can impair renal perfusion in some patients, and therefore monitoring serum creatinine is very, very important. Looks like we might have time for one last question. It says, what is the role of compression garments in the prevention and treatment of post-surgical edema? Well, the issue is that it is not 100% of treated patients that are predisposed to develop lymphedema. Depending on the cancer, anywhere from 15% at the low end in breast cancer to maybe 30, 35% in some of the GYN malignancies, still the majority of patients will not develop lymphedema, and it would be both economically unwise and lifestyle unwise to submit all of those individuals to chronic compression. We do recommend the following, however. Number one is that we recognize that air travel in particular and travel to high altitude is a very common precipitant of lymphedema in somebody who is lymphedema predisposed. So although there are no outcome studies to necessarily support this, we do recommend that patients be given low-grade compression to be worn in an airplane or when traveling to altitudes above 5,000 feet to try to prevent triggering lymphedema if they are lymphedema prone. The second aspect I will mention is that it is feasible to do prospective surveillance of at-risk populations. And at Stanford, we rely on a technique called bioimpedance spectroscopy. Basically, bioimpedance is a tissue characteristic that relates to its ability to transmit a subliminal current. And as edema is accumulating, the bioimpedance of the involved limb will drop because water conducts electricity well. So if we monitor these patients at quarterly intervals, we can detect when they are developing subtle degrees of subclinical edema, and we can then become aggressive in the use of compression to try to forestall or even reverse the tendency to go on to chronic edema. So I think maybe I will stop there because I think we're kind of at the hour.
We are. Thank you so much, Dr. Roxon, for that wonderful presentation. I want to thank everyone for attending today's Morris and Carolyn Barkon Lectureship in Gynecological Oncology Survivorship. We would also like to thank Dr. Roxon for sharing some great information on lymphatic disease. And I think it goes without saying that we appreciate the support of Dr. Barkon and Dr. Lieberman that we may bring you this information. I hope that all of you in attendance found it educational. Please, couple of housekeeping notes. Please make sure that you look over the information emailed to you today to claim your continuing education credits and certificates. Some of you who had logged on using your phone, we may have to reach out to you to verify your attendance in order to get you your continuing education credits. I want to thank you all again. If you have any other questions, you want to throw them in the chat, we'll be able to see those later on. And Dr. Roxon said that he would be happy to answer those, and we'll do a follow-up email to everyone. So I just want to thank you all again for attending, taking time out of your busy schedules, whether you're on the West Coast, East Coast, up in Canada. We thank you all for attending. And if any of you want to join us at the 6 o'clock presentation for patients with patients, survivors, you're more than welcome. You use the same link that you did to get into this meeting. Thank you.